Hello, and thank you so much for tuning in today. We are going to be talking about MS diagnosis. And the reason for this is because there is a large population and high likelihood of MS misdiagnosis. So, we're also going to talk about that in a separate episode. But I thought before we dive into misdiagnosis, it's really important to understand how MS is diagnosed, especially right now, because at the end of 2024, there were some updates to the criteria that is used for MS diagnosis. So we're going to review that as well. When I first became a multiple sclerosis certified specialist, I would say that 90% of the patients that I was working with who had MS had a different diagnosis date than their first symptom date. Oftentimes, during that first evaluation when I was working with them, I wouldn't just ask, when were you diagnosed? I would ask, when were you diagnosed? And when were your first symptoms? And most of the time, the most common answer was about 15 to 20 years gap between the two, meaning they had been experiencing symptoms, whether it was consistent or off and on, for 15 to 20 years before being diagnosed. I will say more recently, that gap has been lessened significantly. Nowadays, when I ask people online in my online community, my virtual clients, when they were diagnosed and when their first symptoms were, it is much more common to hear something like 2 to 5 years. So that is a huge improvement because getting an early diagnosis can often allow you to start taking action sooner rather than later, whether that means you start a medication or supplements or physical therapy or whatever it is. Knowing what your diagnosis is the first step to getting quick and accurate treatment. Getting a diagnosis of multiple sclerosis has lots of challenges because, well, there's actually many reasons. One, there is no single definitive test for multiple sclerosis. If there was, that would be lovely, but that just doesn't exist. So that requires that neurologists gather evidence from multiple resources, including your clinical presentation, MRI findings, spinal fluid analysis, and your personal history. Not only that, but as we all know, symptom presentation is highly variable. So that means the symptoms that you are experiencing can be vastly different, and that can make pattern recognition challenging. There's also tons of conditions that mimic multiple sclerosis, which can lead to a misdiagnosis. And again, we'll talk about that in another episode that is coming soon, but that can make it really hard to get a definitive MS diagnosis. There also can be issues with interpreting MRIs and if they are interpreted correctly or not, distinguishing new lesions from old lesions, the subjectivity in clinical assessment, and balancing early diagnosis with diagnostic accuracy. These challenges are why standardized criteria like the McDonald criteria, which we're about to dive into, is so essential for diagnosis because it provides a structured framework to navigate these complexities while aiming for both accurate diagnosis and a timely diagnosis. If you have my book called The Missing Link, what we're about to discuss is in chapter 1. It's so important that it had to be that first chapter. Understanding these fundamental principles is the first step in taking action. So when we're talking about the basics of an MS diagnosis, the two main things is that to get a diagnosis of MS, there needs to be a dissemination in time and space. And what that means is that your MRIs need to show that you have had an attack at two different times. So not just one attack, but two different ones spread out at different times. That could be a few months apart, it could be a few years apart, but different times. And then dissemination in space indicates that you've had an attack at two different parts of your brain or spinal cord or optic nerve. So it wasn't in the same exact area. Most of the time, when someone is starting to think about getting a diagnosis specifically of MS, there's so many symptoms that could be present, but most of the time it often is something like vision changes, like double vision or blurred vision. It might be weakness in one leg or numbness and tingling in one leg, or extreme fatigue for no reason at all, and it lasts several days, if not weeks or a month or so. And when you're getting diagnosed with MS, as I mentioned earlier, there's no one definitive test. So this often includes a lot of different tests. One that everyone will likely get is an MRI, because this is the test that can actually show us, is there a lesion or multiple lesions in our brain, our spinal cord, or optic nerve. So the MRI is usually a non-negotiable. Another test that you might receive is a lumbar puncture or evoked potentials, which measure how your nerves are working, essentially. And of course, a clinical examination as well. So that's when your neurologist might be looking at your strength, your balance, asking about your personal history and your family history. So that leads us to the McDonald criteria. This was first published in 2001, and its primary purpose was to formalize and standardize MS diagnosis by incorporating MRI findings along with clinical evidence. And before these criteria existed, diagnosis often relied heavily on clinical observations and required multiple symptomatic episodes over time, which significantly delayed diagnosis and treatment. Hence, why the majority of my patients, when I first started as an MS specialist, saw that 15 to 20 year gap. So the original McDonald criteria in 2001 aimed to provide clear guidelines for earlier diagnosis, incorporate advanced imaging techniques into diagnostic standards, allow for a diagnosis after a single clinical attack when supported by MRI evidence, standardize the diagnostic approach, and enable earlier treatment initiation, which research was just beginning to show improved outcomes for that. So we're going to now step back in time and review the evolution of the McDonald criteria, including the newest variation. So as I mentioned, this criteria was established in 2001, but there was a revision in 2005, 2010, 2017, and then now 2024. So I'm just going to share the most important information for you to know from each of these revisions. So in 2005, the revision simplified some of the requirements for the MRI evidence. It clarified the role of the spinal cord lesions in diagnosis. It better defined criteria for primary progressive MS and maintained the need for the demonstration of the dissemination in time through follow-up MRIs, meaning we still had to have different lesions at different times. And the way to determine that was to have multiple MRIs. Then it was revised again 5 years later in 2010. And this revision allowed for simultaneous presence of enhancing and non-enhancing lesions on a single MRI to demonstrate that dissemination in time. This revision also simplified the requirements for demonstrating the dissemination in space, meaning lesions in two different spaces throughout the central nervous system. It made diagnosis possible with a single MRI scan in some circumstances, and it eliminated the distinction between symptomatic and asymptomatic lesions. In 2017, the revision introduced the use of oligoclonal bands in cerebrospinal fluid as evidence for dissemination in time. Prior to this, we weren't necessarily looking at cerebrospinal fluid, but as of 2017, that was one of the biggest changes. It also allowed for symptomatic lesions to be counted towards the criteria fulfillment. It simplified the criteria for primary progressive MS. It added cortical lesions to the criteria and removed the distinction between juxtacortical and cortical lesions. So I want to break down this 2017 revision a bit more clearly. So essentially what it meant was that for patients with 2 or more attacks and objective clinical evidence of 2 or more lesions, they didn't need any more evidence for a diagnosis. They could get a diagnosis right then and there. For patients with 2 or more attacks and objective clinical evidence of 1 lesion, they did need more evidence of dissemination in space. So this would require an additional MRI that would show a lesion in a different location or another clinical attack involving a different site in the brain, spinal cord, or optic nerve. For patients with 1 attack and objective clinical evidence for 2 or more lesions, they also needed more evidence, specifically of another lesion that occurred at a different time through presence of oligoclonal bands in cerebrospinal fluid or new MRI lesions on a follow-up MRI or a second clinical attack. For patients with 1 attack and clinical evidence of 1 lesion, which is also called in some circumstances clinically isolated syndrome, they would need evidence of both another lesion happening in a different space and at a different time. And lastly, for patients with progressive symptoms suggestive of MS, they would need 1 year of progression. So this could be retrospectively or prospectively observed, plus 2 of the following 3. 1 or more brain lesion, 2 or more spinal cord lesions, or the presence of oligoclonal bands in cerebrospinal fluid. I know we're using a lot of technical language here, so hopefully this is all making sense. But the reason that I wanted to break that down is because the 2024 updates are very different than all of the previous revisions. And I personally find that really exciting because to me, that says that research is advancing so much that we have new findings that can be included in the diagnosis of MS. Up until now, it was heavily focused on dissemination in time, dissemination in space, and where the lesions were. But now, wait till you hear what I'm about to share. Now it's just a very different approach that is included. So the 2024 McDonald criteria updates are as follows. And these were presented at the ECTRIMS, the European Committee for Treatment and Research in Multiple Sclerosis, in 2024. And the full publication is expected in the coming months. The panel reviewed extensive research on novel biomarkers and diagnostic approaches. So there's 3 things that are most important to know about the 2024 updates. First, there's new diagnostic markers. Second, there's the addition of optic nerve involvement. And third, there are changes to the dissemination in time requirements. So let's review that first one, which is the new diagnostic markers. So there are 3 new diagnostic markers. First is the central vein sign. So MS lesions frequently form around small veins that are visible on specialized MRIs. So you can't see these on all MRIs, but it does require a 3T or 7T MRI with special sequences in order to visualize these. But they have a high specificity for distinguishing MS from other diagnoses that MS can mimic or that can mimic MS. The proposed criteria is that 35% or more of lesions should show the central vein. In addition to the central vein sign, another new diagnostic marker is paramagnetic rim lesions. So chronic active MS lesions show iron-laden macrophages, which essentially just form a rim. And this too can be visible on specialized MRI sequences. They are highly specific for MS compared to other inflammatory conditions. So this could be huge in getting an accurate diagnosis early versus a misdiagnosis. And these paramagnetic rim lesions, the presence of them indicates ongoing inflammatory demyelination, and they are associated with a more aggressive disease course. So this could be really helpful to know because knowing this information could change which disease-modifying therapy you might receive first. The third new diagnostic marker is kappa-free light chains. So these are proteins produced by B cells during an immune response, and they are detected in cerebrospinal fluid from a lumbar puncture. You might remember that that was one of the tests that I mentioned that you might receive during a diagnosis. The kappa-free light chains are comparable accuracy to oligoclonal bands, but it's simpler to test for, which is great for the doctors and the person being tested. And it may replace or supplement the oligoclonal band testing for that reason. The second update that I had mentioned for this 2024 criteria is the addition of optic nerve as the fifth topology. And optic neuritis is a common first symptom of MS. And visual pathway lesions now count as a separate location for dissemination in space. Prior to this, that wasn't the case. These visual pathway lesions can be detected through an MRI of the optic nerves or a visual evoked potential test, and it helps diagnose patients with prominent visual symptoms. I also had mentioned that there were changes to the dissemination in time requirements. So if lesions are present in 4 or 5 different areas of the brain, the dissemination in time requirement may be waived. This is based on research showing high specificity for MS when multiple regions of the brain are affected, and it can allow for immediate diagnosis rather than waiting for new lesions or a second attack. It does still require careful exclusion of other diagnoses that mimic MS. And lastly, there is new criteria that may allow formal MS diagnosis in radiologically isolated syndrome, which is also called RIS. This is incidental MS-like MRI findings in people who have no symptoms. The current approach is observation only until symptoms develop, but early treatment could potentially delay symptom onset, and it raises ethical questions about being treated asymptomatically for individuals. There were also updates discussed with special considerations for different age groups. So for children, there's more specific criteria for a pediatric MS diagnosis with different MRI appearances. And for people over the age of 50, it's a more conservative approach recommended due to higher prevalence of vascular lesions. There are also additional biomarkers like the cerebrospinal fluid that are strongly recommended if you are over the age of 50. There is a more extensive differential diagnosis workup to ensure an accurate diagnosis. And there is a special attention to comorbidities and vascular risk factors. So what do these changes mean for patients? That's really what all of this boils down to. These changes from the 2024 criteria have the potential for a faster diagnosis and earlier treatment, as well as improved accuracy in distinguishing MS from similar conditions. There's practical implementation challenges. And we're not exactly sure of a timeline for when patients might see these changes in clinical practice. As mentioned, several of the updates do require more specialized MRIs to be able to see these newer criteria. So hopefully sooner rather than later, but knowing these new things to be on the lookout for can make that diagnosis faster and earlier. And if you are not sure if your neurologist is specializing in MS, or if they see a good amount of patients who are diagnosed with MS and you might be second guessing a diagnosis, I wanted to give you some questions that you can ask your neurologist about your MS diagnosis to build your confidence that your diagnosis is accurate. So I have 7 questions that I'm about to share with you, and I will put these in the show notes as well, just so you can visually see them. And these are questions, again, that you can ask your neurologist. So the first question, based on my symptoms and test results, how confident are you in my MS diagnosis? The second, which specific McDonald criteria were used to make my diagnosis? And a great follow-up question to that would be, would the new 2024 McDonald criteria updates affect my diagnosis in any way? I love this question because this will really make it very clear if they are staying up to date on diagnosis criteria for MS. The next question is, can you explain what my MRI results show and how they support an MS diagnosis? The next is, were oligoclonal bands found in my spinal fluid? And what does this mean for my diagnosis? The second to last is, have you ruled out other conditions that could explain my symptoms? Which ones and how? And the last question is there any additional testing you recommend to confirm my diagnosis or better understand my disease? Now, you don't have to ask all of these questions. You can see which ones feel best for you. And maybe there's some of these that you felt like really excited to know the answer to. You can just pick some of them. But these questions can help you feel more confident in your neurologist giving you that diagnosis. I know this was a lot of information, and I will also provide a resource on the updated McDonald criteria for you in the show notes, but hopefully this brings awareness to you that there have been updates made, and it also provides you with knowledge that allows you to feel empowered, even if you've been diagnosed for over 30 years now, or if you're newly diagnosed.